everyone. Thanks for joining today's webinar focusing on bone grafting. My name is Tracy. I'm a marketing manager with Henry Schein, and I'll be your moderator for today's presentation. If at any point during the presentation you have questions, please type them into the questions section of your control panel, and we'll be able to cover them at the end of the webinar. Please make sure that your volume is up and any large computer applications are closed to ensure a smooth connection. This webinar is presented by Henry Schein Dental and Cavo Imaging, and no CE credits are being offered for attending this presentation. Our speaker today is Ben Johnson. Dr. Johnson is an oral and maxillofacial surgeon with Pacific Northwest, OMFS, where he focuses on anesthesia, wisdom tooth removal, dental implants, corrective jaw surgery, and the treatment of facial trauma. Among his many accolades, he is also a diplomat of the American Board of Oral and Maxillofacial Surgery. Thank you, Dr. Johnson, for being here today, and we look forward to your presentation. Take it away.
Thank you. Hello, everyone. Glad to be here. Thanks for Henry Schein for including me in on this. So got a great presentation. It's titled "Half of All Implant Cases Require Bone Grafting." So what I'm going to do first is just kind of go through the cliche introduction. You can see that there is the pre-COVID-19 me. This is during COVID-19 me. Right now I actually have a P100 respirator, which I've been wearing, and you can tune in to see that. So here's a couple of the places I went to school. And this during COVID-19 raises the next question here of what's going to happen next. So there's lots of webinars on that, and actually have one coming up next week for that as well. But just wanted to again talk a little bit about our practice. I'm with Pacific Northwest Oral Maxillofacial Surgeons. We have 5 practices right now. Just 2 are running, and 2 out of the 4 doctors are working, and we're 2-3 days a week seeing anywhere from 1 to 8 patients during those days. So there's lots of webinars going on, and I'm happy to be a part of this. We do basically a lot of bread and butter oral surgery, wisdom teeth, expose and bond, bone grafting, soft tissue, definitely implants, and trauma, and etc. when that comes to the door. I am also an avid user of social media. A lot of you have come to here because of social media, but my Instagram account is PNWOMS, and there you can see a lot of these cases and more. We tried to do some videos during the test yesterday, and it just was really choppy. So a lot of these cases have video with them, which I can't show today, but you can go and follow on Instagram and see a lot more of those videos there. So if you do follow me on Instagram, you might have seen this back in October. There was a debate going on social media about do you use sterile gloves or regular gloves when you're doing implants, and I posted this. So maybe it was a little foreshadowing of what was to come. I thought that was interesting. So maybe a little bit of a profit there on my Instagram channel. Totally kidding. Here's my family, my wife, 5 kids, and we like to do outdoor activities. We like to eat food and have a lot of fun. A couple other things about me. I like horsepower, so I have a Hellcat, and like to take pictures with that. Also was able to climb Mount Rainier last year. I'm moving something on my screen, 1 second. There we go. And other things I've been doing during the quarantine is yard work in my backyard. So I have a pond back there. I installed some steps here last week. I have some goldfish, which I dumped in 2 years ago, and they've grown to about 6 inches. So that's me. And a disclaimer before I start going into the presentation is last Thursday, I'd been working on this for 2 or 3 months before the whole COVID-19 started happening. And last Thursday, 4 days ago, someone in our office opened up an email, and there was a virus attached, and it wiped out anything that was saved to any desktop that was currently connected to the network. So it was a remote computer that destroyed all of my files. So I've been working on this nonstop for the last 3 or 4 days. So I believe I've made it better. If you've gone back through your presentation, you know, a second or third time, you go, man, why did I put that there? So hopefully it's a little bit better than when we started. And again, some of the video, I didn't include any videos because they were too choppy. Okay. So the topic is over half of all implant cases require bone grafting. I'm going to change that to almost all implant cases require bone grafting. Now, that's a bold statement. There are people on both sides of this fence. Some people or clinicians will never graft an implant site, or almost never, and they just rely on biology to make that up. I sleep better at night filling in that gap. So in my practice, the majority of implant cases will have some type of bone grafting. And what we're going to do today is talk about how to identify the right candidates for implants. And then we'll go into how to leverage your 3D imaging software and how to determine the bone graft procedures for the cases using your software. So first one, how to identify the right candidates for implants. I'm going to break that down into a couple of things, medically and anatomically. We'll talk about medically first, and we'll just breeze through this. This is definitely a glaze over what is involved when choosing to do implants on a patient. So systemically, we're going to avoid doing implants on patients who've had a recent MI, cardiovascular attack, or cerebral vascular attack, any type of heart valve surgery within the past, some say 6 weeks, 3 months. So look at the literature on that. Anyone that's uncontrolled or immunocompromised, diabetes, as long as their blood sugar is good, then they're good to go. Someone who's in active chemotherapy, obviously anyone who's abusing drugs. IV bisphosphonates are kind of a hot topic for the past several years. I typically will stay away from doing implants on someone who is currently taking IV bisphosphonates. Oral bisphosphonates is another story. I don't look at osteoporosis as a limiting factor. Anecdotally, in my hands, I haven't seen osteoporosis to be a huge risk factor, but it's more the length of time of use of the bisphosphonate, and if there's any other medications used with that, like steroids or any other comorbidities. So again, be wise with that, and you'll be able to, choose essentially who is a good candidate for implants based on your medical knowledge. Not many people are going to be walking into your office ready for implants if they just had a heart attack. So the majority of patients are going to be okay. The next thing to look at is the intraoral health. If there's any active periodontal disease, gross caries, any parafunctional habits, you want to be able to take care of that for them as well. Anatomically, that's what we're going to talk about next. You want to find out where the bone is and what the final restoration is going to be. There's lots of sayings out there, restorative driven, other sayings about prosthetically driven, and you have to look at both approaches, because sometimes a tooth needs to be in a certain spot and it really is anatomically, you're unable to achieve that. So you have to think outside the box a little bit. And that's where you would talk with your lab, with your restorative dentist, or yourself if you're a dentist who does implants. So that goes on to the next section, the bone graft. Okay, so this is anatomically. This is breaking down how I look at bone grafts. So these are the types of bone grafts that you're basically going to be doing. You can do a socket preservation. You do that at the time of the extraction, with or without a dental implant. So here's a couple of examples of that. This one right here is just a tooth that has been extracted. We did bone preservation with a socket graft, put a little membrane there, a stitch. Here's an example of placing a couple of implants. You can see where that defect is, and that's where we bone grafted and placed a membrane, covered everything up. The other type of bone graft will be a ridge augmentation, again, with or without the dental implant. You can do that at the time of the tooth extraction or after a tooth has been extracted for a while. So here's a couple of those examples. An example of ridge preservation and a socket graft kind of combined. And here's one where the implant was placed, and then we also did a ridge bone graft right there. Next type of bone graft is usually a sinus lift. And again, you can do that in a dental site. You can do that at the time of the extraction. You can do that with or without the implant. And here's an example. Doesn't show the implant, but the implant did go into this area at the same time that we did the extraction, and at the same time we did a sinus lift. So this was a combination of all of those, which you can do. The bottom line with all of this is before you can determine what you are going to do, you need CBCT imaging, okay? So that's kind of a rundown of how to identify the right candidates in your office. The majority of patients who come into your office are going to be a candidate, besides a small handful of health issues that they might run into. I see it quite a bit. Patients come in, they're in for an extraction of a tooth, and they've said, you know, my dentist has said that I'm not a candidate for implants because my sinus is too big. Well, we can fix that. Or I don't have enough height of bone or width of bone. Excuses go on when the patient is perfectly healthy and all they need is some bone grafting. So once they're medically cleared, systemically and orally, and they show up to your office, what you want to do is leverage your CBCT to talk to the patient, try to sell them the case, and determine what type of bone graft you're going to do. Now, these two last bullet points are done simultaneously, in my opinion, because when I pull up the CT scan with a patient in the room, I'm going to be going through this whole workflow that I'm about to show you. So here is our office. This is the iCat Flex. It holds up to 400 pounds. I've had maybe a handful of patients in the past few years who were not small enough to fit in here, but 99.5% of our patients can fit in here. Sometimes positioning is a little funky if it's an older patient and they're hunched over, but we're pretty successful in getting a really clear image with this in the vast majority of our patients. Here's where the assistant stands. They push the button, type in all the information there, and this is a window that deflects any radiographs. So these will give you the types of images that you want to see. Over the past few weeks, we've been seeing images like this, which maybe we don't want to see. So hopefully getting away to all these webinars is helping out. So let's go through the first case. For all intents and purposes, every case I'm going to show you, we're just going to assume that every patient is perfectly healthy. No remarkable issues with any oral or dental or systemic health. So this patient was referred for the extraction of tooth number 14. Stable occlusion, everything is normal. It's just we're just going to focus on number 14. So you can see some caries was involved in that tooth, it fractured. Patient let it go for a few months, and then a little bit of discomfort prompted them to come into the office. So just show you a couple of views here. Can't really see any issues when she smiles. There's a little bit of that cusp was preserved back there. So that's why it wasn't bothering her until it started causing some pain. So my typical workflow for something like this is to do a clinical exam, look at all the radiographs, talk about the patient, what their desires are. We'll talk about the different treatment plans, do nothing, get some type of a flipper or S6 retainer with a tooth in there, some type of space maintainer, do a bridge, and then end with, you know, a dental implant, which is by far the best way to go. So if you're still trying to talk patients into bridges and you're not comfortable with implants or bone grafting, send them my way, send them to someone in your area who you trust to at least talk about it, so then their options are open. And then you manage their expectations. You know, if something is really compromised, you want to be forward and honest with them about what to expect. And then the last thing before you even start is make things in wax, plastic, digital wax, however you want to call it. And this software can help. So this is what I do. This first case, what we're going to do is go through the software just so you have an idea of what I am doing, what my staff is doing with the patient when they first come in. So the patient had their scan, they're in the office or in the consult room, and my team, they're getting everything ready. They're getting the CT scan set up, talking to the patient, going through all the potential risks, benefits. So when I walk in, they have a couple of questions. What my team is also doing is they're saying, we may or may not be able to do the implant at the same time we get the tooth out, or at the same time we do the bone graft. We might have to do this in two separate procedures. We're kind of setting the patient up for, oh man, I hope I can do it all in one shot. Majority of the time we're able to. So we're building up that expectation, that desire. So this is the scan when you first open it up. There's a tab at the top, talks about, or it has different options that you can choose. This section just pulls up a couple of different views: axial, coronal, sagittal, and a 3D image. You can click on this button here and it gives you different options to view. So if you click on the custom plus the 3 sections, it'll show the 3 images here in the volume. You can choose axial, sagittal, coronal, and then 9 sections. For example, I will give you this one right here, where you can choose 32 sections. It'll give you kind of an old school look of what CT scans used to show up to you at the hospital. That's how you used to view MRIs and stuff. They'd show you each slice. You have to look on the screen. So I just like this view initially, just to take a look at everything. I can grab this image right here. I can manipulate it with the mouse to move it all around, up and down, sideways, back and forth. What I like to do then is to go to the volume render section. It just shows me the 3D volume of the patient. And this is nice because you use different tools. I can get the cutting tool. I can put a smiley face into the patient's mouth or patient's face, and I can move it all around and remove pretty much any type of anatomy that I don't want to see there. I'll bring this up right in front of the patient, and they'll look at it like ooh and ah, and take a picture with it. Tag me, and they really like that technology because they won't see it anywhere else. And what I like to do is then, and this is my joke, you probably have your own jokes that you say to every patient and your staff rolls their eyes. This is what I say. I'll move this image to the side and I will use the cut button and say, well, I'm going to get rid of your spine now. I won't do that in real life though. And everyone laughs. Every single time. It's the biggest icebreaker in the world. So I'm going to get rid of the spine. I'm going to flip the head up, remove part of the cranial base, and we've got a nice cleaned up image. Did it show it? Yeah, here's the image. It's all cleaned up. And the next button I'll push in front of the patient is this one right here. I haven't seen this on any other software with this is Anatomage. It's coupled with the iCat. But when you click on this, you can click on any part of this 3D image and then scroll through like you're scrolling through a CT scan in another window. So I'll show them a side view. So, here's the cavity of the tooth. Here's your sinus. I'll talk a little bit of the swelling of this Schneiderian membrane. And then I'll pull up the side view and I'll scroll to it and say, look, here's that huge cavity. There's obviously something going on here. There's a little bit of swelling right there. And I can show the patient where the abscess is, where the periapical infection is. And then they start to understand a little bit better versus looking at a 2D X-ray. What's nice about this is you can take this image and drag it in any oblique possible way that you can, 3D, and then scroll through this. So this is a look from this direction up at that tooth, and kind of a pointless view, but it's good when you're looking at lesions or trying to figure something out that you can't quite grasp on a fixed axis CT scanner or a 2D image or a Panorex or something. Okay, the next view that we'll bring up, usually my staff is doing this part, is in the arch section, this is before I come in, they're going to highlight this button and just trace the mandible. Now this one was an auto traced one, and you can see this is the image that comes up from the auto trace. So you can manipulate these little points right here. Again, this is pretty basic CT stuff, and then generate an image like this. Those points are along the arch of the upper and lower jaws a little bit better. Now, if that's still not good enough because it takes out a little bit of the anatomy right here, you're missing some of the anatomy of the condyles, the front teeth, then you can hit, well, before you do that, you can scroll through this image. So this yellow line was right here on the arch. If I scroll with my mouse, it'll take me in either direction along this frame, this reference right here. And this is the image that pops up. So as I scroll through here, the Panorex scrolls through. And again, I wanted to attach some videos to this so you could actually see it going, but it was just too choppy. So scroll through the arch. If that's still not a good enough view, then you can hit the true pan button. It'll give you an image like this, which you can sharpen up. And what that does is it just takes any part of that mandible or maxilla in between these two white lines right here, and just smushes them together into 2D image, which you can sharpen up. So we'll usually show that to the patient. So, you know, your sinus is a little borderline there. We may or may not have to do a sinus lift. And they're all praying that we don't have to do a sinus lift, because who wants a sinus lift? Sounds horrible. I like to say vertical augmentation. The other thing you can do is pick as many points as possible. So this image right here, 1, 2, 3, 4, 5, it has 6 or 7 dots. If you want to be a little bit more detailed, you can go overkill and do 100 dots right there, generating the same issue or same thing. The other thing I will do is pick the measurements right here, and there's a couple of different measuring tools. This one measures the length of the whole arch. This one will measure a line, and these can be manipulated so you can measure different heights and widths of bone. Right here we'll measure degrees and the length of each one of these arms, and then there's a volume measurement. So this is more handy if you're trying to measure the volume of a lesion or something for whatever reason. You want to determine, you know, if there's a large cyst or something and you want to be pretty accurate with the amount of bone graft that you're going to use, then you can use that. And then this one will just measure a linear line. So very useful tools. Most softwares will have those in them. Another one that I like to use if you're a specialist or you're trying to communicate to a specialist, these tools can be valuable. There's an arrow, you can point to stuff. There's a circle, you can highlight stuff. There's some words right here that you can send. So obviously I send this out to all of my local dentists. Please send me thirds. And then this box measures Hounsfield's units, which will kind of give you the mean, the average, minimum of bone density. I don't use that one too often, but it's there. It's a useful tool when you're really looking at that. A couple other features. There's a panel feature, generates the same type of image we just looked at. There's a cephalometric feature that's good for ortho or surgical planning. So that's kind of the rundown of the CBCT ICAT that we use. So that's just kind of assume that we're doing all this for all the next patients. And then we're going to show you some before and after photos of these cases. So we're still talking about number 14. I have not forgotten about that. And to go along with some before and after cases, here's a couple of good ones. You know, this is me right now putting on that quarantine. Okay, funny joke, right? So then we go to this implant tab right here, and this pulls up the 3D image again. I've cleaned it up. I've gotten rid of the one half of the face, so we're just looking at one half of this arch right here. Neck is gone, cranial base is gone, so it's nice and clean for the patient. It takes 2 seconds. I do that in front of them again so I can do my joke, make them like me a little bit more, and then I'll click on Add Implant. It'll come up with an implant selection. I can click on all of the implants. I can click on one, so that's what I'll do. I'll click on the one implant. It'll give me an implant floating in space. It's attached to my mouse. So again, in video you can see this, but imagine that this implant is floating right over here. I'll click, it'll somewhat position that implant in the right spot, and then I can manipulate this in front of the patient. You can choose from any implant out there. Straumann recently came out with their BLX implant. It took the iTero or Anatomage team maybe 2 weeks to get the specs into here. So it was pretty quick. If there's new implants that are developed and come out, then you just got to let them know so they can get their hands on it and scan it in and put it in. So this is a true to life version of the implant made by the manufacturer that comes in, pretty much gets rid of any type of magnification errors, and makes for a pretty accurate diagnosis. So for all intents and purposes, I just chose a generic implant for all these cases. But I'll place this implant in here and I'll take a look, I'll manipulate it around, I'll show the patient, and there's different volumes. So this is the volume of the implant. You can click on the implant, it'll give you an outline of the implant. You can include a restoration, stone models, or your iTero scan can be incorporated into this. So they're fairly easy to merge. I don't have any examples of that. I lost them all with that virus a couple days ago. But for the most part, you can put the implant in there and you can figure out or show the patient, what are we going to do? One of the other features, this is because we're trying to figure out if we need to do a sinus lift or not, is this button up here. So you click on this button and it will give you a little arc right here. When you click right here, it'll measure the amount of volume that you're going to need of your bone graft for your sinus lift. So this is estimating 0.5 cc's. My only issue with this is it does not distinguish between the membrane of the sinus or the sinus floor. So that gets a little annoying, but I can deduct that this is roughly the amount of bone I'll need for this area right here. And so I'm going to guess I'll need 0.5 cc's of bone graft. I use Mineros. So I'll tell my assistants, we're going to use 0.5. And then 2 seconds later, I'll say, you know what, open the 1 cc because we're going to bone graft right here as well. So looking at this image, I can see that my implant, the apex of my implant, goes into the membrane, a couple of millimeters. That's not so bad. I'm not too worried about that. I would still usually bump that a little bit. My worry is this view, is the sinus comes down right here, and on the back part of the implant, just right in here where that sinus dips down, that's going to be more exposed. So I don't want any perforation right there. So when I get this tooth out, most likely I'll be doing a sinus lift. So patient sad, yes, we have to do a little crestal graft right there. The other thing I'm going to be determining will be, can I do the implant at the same time? So side note, I'm doing a sinus lift. Can we do the implant? I'm trying to get the patient all excited in anticipation. Are we going to be able to do the implant at the same time? Because they just want to come in for one procedure. So my assistants have said maybe. I've been saying maybe. I have a good idea of what I'm going to be doing already at this point, but get them on the edge of their seats. Then they're really paying attention. Side note, you can attach a restoration to the implant. That helps you determine, is your implant in a good position? Is going to be projected? The crown can be moved around, the crown can be manipulated, change in size. Your abutment can be customized right here. Again, totally another topic for another day. But that can be placed in there. It just helps you be a little bit more accurate with your implant placement when you're trying to determine if you need bone graft. Because you don't want to put the implant where there is bone if it is not prosthetically or restoratively driven. It doesn't make sense. Now you're back to the 1980s, 1990s. Okay. So patients on the edge of their seat, we have to do a sinus lift or a little vertical augmentation. We're going to be doing some bone grafting. We're going to be getting the tooth out, but can we do the implant at the same time? So it's all positioned right here. And what I look at is this top image right here will show me, well, how widely spaced are these 3 roots? To me, that looks like plenty of interradicular bone that I can get this implant into. Now that interradicular bone might only be 1 millimeter. So then I look at this image right here. I make a measurement, right down here, and I can see that I have about 5 to 7 millimeters of bone in between the mesial buccal, distal buccal, and palatal root of good bone that I can get into. That might be a little bit over exaggerated right there, but 3-4 millimeters, I'm going to put that implant in, or at least try. Okay, and then I'll be bone grafting these residual sites afterwards. So look at height, look at width. You can do all this in front of the patient, and then you say, you know what? You're a good candidate for an implant all at the same time. And then they're happy, they're ecstatic, and you can move on with life. Side note, not going to really talk about this, but for any of you interested in airways, this also does volumetric airway analysis. It's a great tool for anyone who is interested in sleep dentistry. So then we present this to the patient. We can tell the patient with a great deal of confidence that we're going to extract your tooth. We're going to bone graft the residual site. We're going to do a small vertical augmentation of the area because you see the implant on the image is poking through into the sinus a little bit. And I'm going to do an implant all at the same time. I never promise. You just say, I'm going to attempt. There's a whatever percentage likelihood that I'm going to be able to do it. If I don't know, it's 50-50. I never go below 50. Because 50-50, it's a good shot. If I have a really good idea, 95%. Never go to 100. So in that range. And then some options, plus or minus IV anesthesia. So the patient has visualized the treatment plan. I have visualized it. It's fast. It's easy to understand. This takes, again, about 10 minutes to talk to them and answer questions after my staff and team have already educated them. And then you can save these images to the chart. So we'll usually just take a couple of screenshots, save it to our image holding software, and it's there for future reference. We'll attach those with all the photos that we take during the exam. And it really just takes the guesswork out of the whole thing because we have visualized it, we know what's going on. Now, it's not 100% accurate, that's why you have to correlate clinically. And then sometimes when you get into the site, the infection is way worse than what you saw on the x-ray. We're all aware of that. But generally, we know what we're going to be able to do. And it helps dumb it down to the patient level as well. Not that patients are dumb, but they just don't know, so it makes them an idiot just as much as I am an idiot when it comes to rocket science. Okay, so let's go through the case. Number 14, shave down the mesial buccal cusp. I want to take this tooth out as atraumatically as possible because if I start cranking on this, like in residency, then there goes the buccal plate or there goes all that furcal bone that I wanted in between the roots. So I'm just going to go nice and easy, make some cuts. I like to use a spade elevator. We have spade elevators from Hugh Freedy, Henry Schein sells them. A-Titan, those are a couple of my favorites. But that's my go-to instrument for almost anything. If I was stuck on a desert island like Tom Hanks in Castaway, he used an ice skate, I would just want a spade. I could handle it, okay? So just luxate those, they all come out atraumatically. And you can see the extraction site, and that's all that good bone that I want to get to. That's usually also the level of the implant platform, which I'm going to take the implant to, because it's plus or minus usually between 3 and 4 millimeters below this point on the adjacent teeth, the apex of the CEJ, direct facial of the adjacent teeth. That just provides for a good emergence profile. So that's where I'm aiming. Here's the osteotomy site, went pretty good. Now, when I do my osteotomy, I'm going to use, well, each implant company has different protocol for soft, medium, or dense bone. So usually I'll use the implant company's protocol for soft bone, mainly because number one, it's the maxilla, and this bone is fragile. Sometimes you get a fracture of one of these walls, palatal, mesobuccal, distal buccal, and that can potentially lead to not being able to place the implant or the implant failing or just having to graft it. So I'll undersize my osteotomy and I'll also shorten it because I don't want to perforate into the sinus yet. So I'll go to an undersized drill. I'll drill up to the floor of the sinus and stop short, and then I usually will finish it off with a densa burr for something like this if I'm doing an indirect crestal approach sinus lift. So you can see that right here. I've partially grafted the outside. I left my densa burr in here, graft a little bit around some of these areas, and then slowly using the densa burr, we'll place more and more graft material into this site. Then I'll place the implant. Again, it's been placed, or I've used undersized implant drill. So the implant goes in, and this actually torqued to like 50 Newton centimeters, which I'll take any day. It's a Straumann BLX, very aggressive threads. And then finish off the bone graft. I'll take a curette, and I'll usually, I don't want to do this too much to not strip as much blood as possible, but just gently, went backwards, gently take my curette underneath the facial flap, flip it around, go underneath on the palatal, just to create a little pocket, almost like an envelope where I can stuff my membrane into. So this is a BioHorizons Memlock membrane, and just stuff it there on the facial. Sometimes it gives this a little bit more oomph or thickness, and stuff it on the palatal. 2, 3, 4 stitches max, a couple of views here. And I know some of you OCDers have been looking at this restoration right here. Just want to say that I'm an oral surgeon, so I didn't even catch this until someone pointed out to me. It was on an Instagram post, and I said, oh yeah, there it is. So that's one reason why we take photography. So that will go into my wheelhouse for next time, to not be so tunnel visioned, and I might just shave that down a little bit. Help contour that tooth a little bit. And then here's the pattern which I usually suture. These two on the outside for papilla, and then either the knot right here or the knot on the outside. And just a quick figure of 8 helps hold that membrane down and holds the mucosa together. Get the stitches out between 4 and 6 weeks, and this membrane will resorb. So here's the x-ray the day of the procedure. You see the bone right here, and then an x-ray 2 weeks later. And this was, again, very straightforward because it was exactly what we planned for in our cone beam imaging and based off of our clinical exam. So implant placed at a good height. Our bone graft is placed perfectly in that area, using the proper instrumentation, and right now we're healing. We have pushed her follow-up back a few months because of the whole virus thing. So if you're like me, well, let's see, depends on what time zone you're in, but it's around lunchtime right now. I haven't had lunch yet, but I'm kind of hungry. Usually I've been working on my first or second lunch right now. If you're East Coast time, you're probably on your third or fourth lunch. We're starting first dinner right now and working into second or third dinner. So let's go on to case 2 while you're hopefully eating something right now. Patient came in for a couple of things. One was a biopsy. This ended up being a fibroma, just a clinical pearl. If you're doing a small biopsy in a high traffic area, meaning it's going to be touching the teeth or on the tongue, I like to bury the knot. So the knot is right underneath there. See that? Just tie it. It's a couple chromic. Heal up just fine. So this patient was referred for, you can't really see based on the clinical X-ray or images, but referred for extraction number 13. Right, my mouse is working. Right back here. Right back here. Okay, so we're just going to assume perfectly healthy, no problems. We're just looking at the X-ray, talking with the patient. So we've done our clinical exam. We're going to look at the radiographs, talk about the patient desires, manage expectations, and then make things with wax or digital wax, etc. This is going to be a lot quicker because I've already cleaned up the images while I'm looking at it with the patient right here. So obviously there's a nice vertical root fracture right there. Most of the buccal plate is gone. A lot of the palatal wall is gone. Another image right here where she can clearly delineate a large vertical fracture. And it's been there probably for some time because this looks like a pretty sizable defect. and the sinus. So already when I'm talking to the patient, there's a pretty good idea there that I'm not going to be able to do an implant at the same time. So instead of trying to get them all anticipatory and, oh, can they do the implant? I just kind of break the news very quickly. Probably have to do this in 2 stages for you, sir or ma'am. So you can see here, I've cleaned up the image, just showing that side of the face, placed an implant, positioned it likely where it's going to be, and then patient looks and says, oh, that makes perfect sense. I see the fracture, I see where that implant needs to go, and I see that there's no bone to support it right when the tooth comes out. I don't necessarily have to, though, do a sinus lift, saved by a little bit of that partial extra sinus wall right there. Couple of views. I also look at it restoratively. So there's an option right here where you can get a projection of the whole implant poking through right there. And I'll always look at that too, just to make sure that that implant is in a restoratively acceptable position in my pre-planning. So again, tooth comes out, being atraumatic as possible. I preserve this mesopapilla because there was a little bit of a buccal periolus right here. This papilla broke down pretty quickly. But again, tooth out, place our bone graft, place a membrane and sutured. And prior to the treatment, we can tell the patient with confidence, we're going to get your tooth out, we're going to bone graft. There's likely no need for future augmentation. We'll let it heal for 3 months and then we'll come back in, we'll place the implant. We'll just add a couple of months to the overall treatment, and then optional options that they can go forward with in the future would be, you know, IV anesthesia. Do they want to immediately provisionalize this with a crown or a custom temporary abutment? And if we're going to do that, then I usually use guided surgery, and then everything would be done or made pre-fabricated. I'll tell you which lab I use in a few. So for this patient, use 3.0 chromic gut from Schein. Our bone graft was Mineros. See an example of it right here. Use a Memlock membrane. That was Colla tape over the top. Just source that from Salvin. They have really good prices. And my other ingredient, TLC. Okay, so those are pretty basic. We're already at the 45-minute mark, so I've got 2 more cases. I can skip them. I can't really tell what the feedback is right now, if people want to stick around or not. Maybe you can, let's see, type it in. I can't, well, no one's leaving, so we're just going to keep going.
I see some comments here that say keep going, so go ahead.
No, we're going to keep going. These next 2 cases are a little bit more advanced and very tricky. So you can get back on my screen. Case number 3. This patient presented after, well, from her dentist. She'd been in a car accident 50 years ago, and they pretty much masked the fact that she has no premaxilla with crown and bridge. So here's a couple of views. Again, systemically cleared, dentally cleared, everything's in perfect health. There's some, bone loss and so on, but that's all stable. Everything's stable. And she was in a motor vehicle accident 50 years ago. Access to dental care was poor in the country she came from, and her anterior bridge is now failing. We've seen her in the past for a couple of implants on the lower, which you'll see, but she presents with an abutment on 6, 4 pontics, and then 2 abutments. So it's a 7-unit bridge. I can count really quick. So some of these views I haven't really shown you are too bad, just looking at them, because it's, again, 2D, but this is where the cone beam imaging will really come in handy. Look at the projection of that bridge work and all that thickness, and the fact that there is no maxillary bone. Now, she probably could have benefited, back in the day from a Lafort advancement, maybe a setback of her jaw, but we're well past that phase in life. So what we're going to try to do is give a little bit of bulk right here, and this her desires is decrease the bulkiness of her crowns. Now, if you look at the smile, it's not that bad. The crowns are kind of flared out a little bit, and she doesn't really like that food trap in the upper. So we say, well, those are potentially reasonable expectations, but here's what I see based off your x-ray. And they look at this x-ray and go, oh man, I really see how far those crowns are projecting and how little bone I have. So it helps that out. And there's a couple of implants that we did in the past. So she trusts us, we trust her. This is also being addressed at a later date, but right now we're focusing on this. So patient desires, check. We're trying to manage her expectations of, we got to do a pretty significant bone grafting here. Your jaw bones aren't necessarily in the right position to give you that perfect Hollywood smile. But we're going to plan it all out and see if they like that plan. So ended up deciding on doing 4 implants. I like to go as symmetrical as possible when you can. So instead of doing an implant in position 8 and 10, I will usually do 7 and 10 or 8 and 9 and try to mirror it right down the midline. And that's more, this is a whole nother topic to get into of where to place an implant, which teeth are there, which teeth aren't. Do you place an implant next to a tooth? Do you place it 2 sites away from a tooth when you're talking about going across the midline? But the idea here was to try to get a good projection, was maybe to place implants and do like a partial hybrid type restoration. So we place the implant, or sorry, so we plan the implants here. Here's a worm's eye view. Here's the projected view. We bumped these implants out a little bit, and you'll see here on the following x-rays where we would have to bone graft. So pay attention, right in this area, that's where we're gonna have to get our bone to get out to, is right there. I didn't think that was reasonable, so when we planned this, I actually bumped these implants back a little bit, and I kind of flared them out just a touch. When doing tricky cases like this, I suggest finding an implant company that has a screw or an angled screw access channel. The 2 main ones I know off the top of my head are Nobel and Straumann, where if the implant is projecting out like this and you want a screw retained screw this position, then you can actually still obtain that with a different screw and screwdriver or implant driver, restorative screw drive. You know what I'm saying? I don't use those parts. I use the surgical parts. So that's the kind of the plan. We're using Straumann implants for this. Show the pan like the Panorex like this. I can take all these images, quickly save them, send them off to the dentist. We can take these, we can merge the digital wax up, the real wax up with all of this and try to get, okay, what's realistic for our projection of the implants and what can we actually accomplish. I also wanted to do this one guided because we had to be pretty accurate, mainly because, we'll get to that right now, mainly because for these implants to be in a good spot, these are 10mm implants. I hesitate using 8mm implants with such a drastic projection on them that I wanted a little bit more length and a little bit more width. So this is not the sinus, this is actually the nasal floor. So right here, and you'll see in a minute, is her bone was pretty short in the anterior. So with the 10mm implant at the right position, we're gonna have to go into the nasal floor a little bit. And that's what makes this a little bit more of a challenge. I wanted to get some planning pictures attached to this from Golden Dental Labs. They use a proprietary software from Straumann, and I guess Straumann archives that software after it's older than 3 or 4 months. And this was done just late last year. So we were not able to obtain that in time. But trust me, it was good stuff. With the software, we were able to, just like we did on this one, do a digital wax up per se and move on the case. So here is, we're doing immediate right here, and immediate right here. And then in tooth 7, that's where we'd have to do the little bit of a nasal floor bump, as well as tooth 10 right there. So here's the case. Got a little close up with my my camera. My assistants go a little wild when they're feeling like it. So get the tooth out again. doesn't really matter traumatically, atraumatically. Does atraumatic, I don't even like that word atraumatically. It's traumatic, you're getting a tooth out. You can be less traumatic. How about that? We got the teeth out. These pretty much wiggled right out, and I wasn't too concerned with anything with these teeth except for preserving the buccal plate because I was going to open it wide up. So nice crestal incision. I did vertical releases on the both sides of the flap, exposed the anterior nasal spine, and then if you were to put your finger in your nose, this and push down, that's where your finger would be. So just a point of reference, this is the nasal mucosa. If your finger's in your nose, on the other side of the mucosa right there would be your finger, digging for gold. Well, right here, we're trying to put gold in, so we don't want to perforate right here, otherwise we'd be in the nose. But there's a membrane right here, kind of freed up the anterior nasal spine that gives us better access. And then we used a freer, or it's kind of like a periosteal elevator to lift up this mucosa a little bit. So when we do our osteotomy, we're not cutting into that. Benefits of guided surgery. You don't want to fully rely on guided surgery. There's guided surgery, there's freehand surgery. Again, I picked this up from one of the prosthodontists who lectured to us just recently. It always has to be brain guided surgery. So I actually think guided surgery is more advanced than freehand surgery, mainly because sometimes you're working blindly, you can't see, and if you fully trust that your technician made this guide accurately and printed it off accurately, etc., there's lots of margins of error, then you can place it blindly. But I still check. I'll take this guide out, I'll check, look at reference points, etc. But this helps me get the implants in a good position at the proper depth, etc. So implants are placed. Let's see, where are we? Okay. Nasal floor has been lifted, and now we've got to do our bone grafting. So use an instrument to lift up the nasal floor. We grafted into those sites. Again, this is trying to think if this was Mineros. This is probably Mineros. Grafted into the sites, and can't quite see it. There's some dehiscences on the bone on both of these sides because we're trying to get some of that projection out a little bit. So there's the grafted site, and after that, then we start filling in those gaps. Now remember, we want some pretty good projection right here. I could have used block grafts. I don't use those very often, and I've had actually really good results with this one. My next case is actually using block grafts to get a good result, but we just wanted to try it this way without having to do the block grafts because we were placing the implants at the same time. That was the goal, and I didn't want any screws getting in the way from the block grafts. So grafted partially both sides, packed it down, grafted some more, had really good projection. Now for this, I placed a membrane on underneath the palatal flap, and then we placed another membrane over the buccal or labial flap. And so there's a flap coming from the palatal, flap from the buccal, so it's pretty much double membranes. These are both collar tape. And then I placed a fibrin clot or a PRGF membrane. There's lots of systems out there for platelets. We use the PRGF system made by Endoret. It's by BTI. If you search BTI North America, then you can find it. But you get some good platelets, a good platelet clot, and we combined all that. And the key to this is to get really good passive closure. So I was constantly checking the flap after I packed it, after I bulked it out, get my membranes in the right spot. And this is the passive closure I was able to attain prior to suturing, which I thought worked out wonderfully. Good keratinized tissue all around, and so we sutured that shut. And all these implants actually went in really tight, considering what we were working with. I believe greater than 35 Newton centimeters for all of them. So we put the healing abutments on. And here it is immediately thereafter. And there it is a month later. Now this was late last year, like I said, she was going to come in and we were going to see the final restorations. The dentist had been working on contouring the papilla, but then pandemic hit and we just changed everything. So hopefully I'll get that up on my Instagram channel in the future. The sad part of being an oral surgeon is you rarely get to see the final result. We call patients, say, can you come in and get a picture? Like, you want me to come in just for a picture? Yeah, and no one really shows up. So with that said, we've shown 3 cases, and my stance is most cases need bone grafting, but not every case does. So here's kind of a really quick case. I actually have 2 more cases left after this. I'll go quick. Everyone's seen hybrid surgery. This patient had so much bone that we actually didn't really have to do any grafting. I was able to angle both implants on both sides, past the sinuses. This is one of those cases where patient walks in and they have those 2 key factors. Usually patient will walk in and they'll have money but no bone, or they'll have bone but no money. Patient had both. Okay. Again, money's not a determining factor, but a lot of times that's what it is. Especially when you're doing a full arch case, you're gonna be spending a good chunk of change. So we plan this out digitally. We can see on these images that there's plenty of bone if we angle these implants just right. Potentially would have to do some bone grafting right there, but ended up not needing to. Here's the implant on the contralateral side. Again, stayed away from the sinuses, lots of bone, even after reduction. So with that said, I still use bone because I like to, it just makes me sleep better at night, bone graft between the gaps, graft the gap, as they say, between the implant and the socket site. So we'll really quickly go through. This guide, again, was made by Nick at Golden Dental Labs in Spokane, Washington. And it was planned initially on the anatomage, and then for the implant guide, he had to plan it on his software. But I was able to determine during the consult that he had plenty of bone, nothing really to worry about. We charge a global fee for cases like this, so if I had bone grafting, he doesn't pay more, or she doesn't pay more, the patient doesn't pay more. So bone reduction, you've seen the story. Place the implants, check projection. We have a pretty unique workflow. We'll take an impression of this, and then I'll go see other patients while my lab guy, Nick, is converting this denture indirectly. And then I'll come back, I'll seat it real quick, or the dentist will seat it, and there it is, ready to go. If 2020 was a car, it would be a Prius being held together by duct tape. Okay, last case. I know we're going over a little bit. This is the block graft case that we talked about. So again, patient came in, a little bit of some hygiene issues, previous jaw surgery patient. You can look at the panel, so there's some bone loss, a little bit of bone loss right here. But according to the dentist, it's all stable. These teeth, these lower anteriors are being held together with some composite or some type of splinting material, but everything else is stable. Okay, so you look at this and go, it's not too bad. She needs the treatment plans to remove 23, 24, 25, and 26, and place 2 implants. Do that frequently, all the time. So we bring her in. This is the importance of getting 3D imaging, and get smacked in the face with this. There's absolutely no bone. There's good height, besides a little bit of periodontal disease, which is now stable. But look at that thickness. There's nothing there. So this becomes a little bit of a challenge. But I know that before I open this site up, I can talk to the patient about the risks, benefits of the procedure, and this is where we need the implants to be. So the patient can visualize that during the consult, say, we're going to place these implants roughly in this position. Look how much bone we don't have. And that's a challenge to build that up. Height, we're good. So that was one of those factors in our favor. We also had about 3 or 4 millimeters of thickness right where the tooth was kind connected to the bone, and then we didn't have any where the tooth wasn't connected to the bone. So the plan was to extract 23, 24, 25, 26, and I was actually going to use cortical block grafting and then PRGF allograft particulate. I was going to pray. This is again where you manage expectations with the patient, let it heal for 6 months, and reevaluate, with the caveat that we might have to be doing some more bone grafting in the future, or it just might not work and we'll have to do something else. So day of the procedure. Now these photos were taken pre me taking when the pictures really matter. So if you've taken those courses before, they're fantastic, and I try to teach some of those same principles to my staff. So a lot of times my staff will take these photos. We've got the site opened up. Again, did 2 vertical releases away from the site. Decorticated, didn't take much to decorticate this bone. I did that because I was worried a little bit about the blood supply to the area, so I wanted to get some good bleeding. You can see there's some good bleeding down south. I had some really good videos with this too, just couldn't work out for this webinar, so maybe in the future. But I packed, it doesn't show it, released the lingual flap right here, and then used a collotape membrane, just a large uncut collotape right there, to pack a little bit of bone graft on the lingual. Used cadaver hip allograft. This is from Zimmer Biomet. Held them in place, and then I grafted everything with my particulate. Now, I think this was a few years ago. This was pre popularity of sausage technique on Instagram. But here's one of the original sausage grafts, and I overbulked this a ton. These are OsteoGuard flex membranes and some collotape over the top. Stabilize them. Again, the trick is really passive closure. So there's some good releases, expose the mental nerve on both sides, which I didn't have enough time to show you. That's a really good feature for feature with the software, is you can map out where that nerve is in the mandible. So I knew where the nerve was. After that, good primary closure. And then this is the closure. I told the patient, don't breathe through your mouth for 6 months. She didn't. She just breathed through her nose. It was amazing. She held her breath. This is a month later. So you can see my graft underneath this really thin mucosa. Again, that was one of my worries, and I told her about that. At the time, was the blood supply to that area. But luckily, everything happened. No dehiscences, lost a little bit of thickness, and you can see some of that cortical bone graft was kind of showing through, but we were able to thicken that up at 2nd stage surgery. So she came back after 6 months and did the same thing, cleaned up the skin, mapped out the nerve, placed implants where we thought they were going to go, and then these implants are actually placed in the exact same spot as they were pre-surgery, right here. So place those implants in the same exact spot. So that's pre-surgery. I was just really ecstatic about this result. I think we got pretty lucky with it as well. You can see one spot right here where that might need to be grafted at the time we do the implant. And again, this CT scan isn't showing the amount of bulk that we had when we re-entered this site, because it doesn't pick up some of that finer imagery that you need. So place those implants in a good spot, and you can see the amount of thickness we're able to obtain. And this is a good time where you can measure Hounsfield units, see the density of the bone in that area. And this is that one spot I showed you right here, where we might have to bone graft a little bit more when we place those implants. Implants went in, day of surgery. The healing abutment was placed, which to me is a sign that the implant went in tighter than 35 Newton centimeters. I don't remember the exact value. And good oral hygiene, and here's the result a couple weeks later. Those are out of order. Here's the day of the procedure, and then a couple weeks later. Artistic shot. So bottom line is, when you are doing implants, most likely you're going to be bone grafting, and your cone beam CT is going to be a really good tool for you to figure out what type of bone grafting you're going to be doing, so you're not going in blindly. You can pick the size of the implant that you're going to use based on where the nerve is, based on where the sinus is. So you can customize it to the patient. Then you can customize the procedure to the patient. You know where to graft. There's no surprises. Sometimes that small buccal periosteal is actually a large defect, which you wouldn't figure out on a Panorex or a PA. You might not even see that on a cone beam, but you get a better view on the cone beam. And there's some things that you can check or look at in the cone beam to give you a good idea. Again, lateral augmentation, no surprises. I knew we were going to do this. Here's that small buccal periosteal that was there that ended up turning into a very large defect. So I just removed the fistula from that site, stitch it up. Sinus lifts at the time of the procedure, afterwards. Bottom line is, you don't want to do this on accident. You want to do this on purpose, okay? So this was planned for ahead of time, and just want to, again, thank you for sticking around till the end. A huge shout out for Henry Schein for giving me this opportunity. Here's my list. Webinar. Check. Thanks, Henry Schein. Thanks everyone who participated. I like to try to get a picture of my audience.
And we do actually have a couple of questions.
Yeah, no worries. We can do questions. Let me get a quick picture of my audience right here. There, I'll post that to Instagram.
So the first question is, do you do periosteal releasing incisions for passive primary closure?
Oh, for sure. That's almost a given when you're doing if you're bulking up a site. So you start off with a site that's this narrow, you're bulking it out, so you got to get that soft tissue to close over there. So definitely we'll do a soft or a periosteal release with those. Get a nice sharp 15 blade.
Great. Here's another one. Any concerns with impinging the nasal breathing when grafting up near the nasal floor?
Yeah, so let me see if I can go back to that. I'm glad you asked that, because I was going to talk about that. One thing that you want to look at is, and you can determine that on the CT scan, is how much volume is there in my pre-surgical planning. So I don't show it, but if you look at a coronal slice right through here, because that's where the implants are, and you can see where your implant is, then you can see how much nasal volume is there. If you're going to be running into a turbinate or something, you might be too far back with your implant, but that's something you want to look at. Is there any swelling, a deviated septum, something that's potentially going to cause a blockage right there? And we weren't lifting that up very much in this area. But yes, good question. Something I definitely check on.
Great. Here's another. Do you stabilize membranes with periosteal sutures or tacks?
Sutures. I have never used a tack in my entire life. I used to do the Sonic Weld by KLS. I just wasn't really good in my hands, so I usually use periosteal sutures, either chromic or quick resorbing bicryl or even PTFE to hold those in, but rarely tacks. Should I? You'll let me know if I should use some tacks. There's probably been some cases where I wished I had tacks, but I don't know. Not many people I've talked to really like them.
Another question. For an immediate implant, is there a specific guideline you use to determine how much stability you have with placing?
Is there, say that one more time?
for an immediate implant, is there a specific guideline you use to determine how much stability you have with placing?
So I'm going to guess that when I place the implant, well, I'll answer this one globally. When I place an implant, I have had spinners, and I just put a closure cap or a cover screw over it, bury the whole thing, come back in 3 or 4 months, implant is integrated. So I've done things from 0 Newton centimeters up to, I think with some of my Zimmer Biomet implants, the T3s, I got up to like 150 Newton centimeters of initial torque. So with immediate implants, it just kind of depends on the case. Obviously, if the implant's all floating around, I'm not going to leave it in place. I'll take it out and just graft, but I get a little cowboy with my immediate implants as far as torque goes. Hopefully that answers that.
Yeah, maybe we'll take about 2 more questions. We have a few here. What is your opinion on grinding an extracted tooth and using it as graft material?
I've seen that. I know I have those dentin grinding, toss a tooth into the grinder, and yeah, I just don't know. What if there's bacteria on the tooth? I just like to use sterile allograft or autogenous bone for that. No opinion. Never used it.
Okay, and here's a final question. The doctor mentioned that he can add a restoration to the planned implant on the CBCT. Does he integrate it with CAD/CAM scan or no need to integrate with this system?
So if I understand correctly, you can digitally add a crown or an abutment to the cone beam CT scan, or you can take an iTero or a digital image from the patient, merge it to the software. As far as converting that over to CAD/CAM, I am not sure because I am not a restorative dentist. I'm sure someone at Henry Schein could answer that though. You probably have a lot more success using the software that comes with your CAD/CAM machine. But again, totally out of my wheelhouse because I don't do restorations. I'll place them there so I have a ballpark idea of where that implant should be or where it shouldn't be, but I don't go that far as to restore it.
All right. Well, great. Thank you, Dr. Johnson, for those great answers and for your presentation. And thank you, everyone, for attending today's webinar. We really appreciate your time and participation. As a thank you for attending, you will receive a link to view the recording of today's presentation in the coming week via email. So on behalf of Henry Schein and Cavo Imaging, thank you again, Dr. Johnson, for an amazing webinar. And thanks so much once again to all of you for attending. Have a great day.
Thanks, everyone.